Welcome everyone to another WIC Works webinar from the California WIC Association. We're glad that you've joined us today for the topic of best practices for breastfeeding support in community clinics. This is Margaret Aumann, Communications Coordinator with CWA, and I'm here to moderate your webinar. I'm also here with our host, Karen Farley from CWA, and we'll have two very enthusiastic presenters today, Jonathan Goldfinger from Children's Hospital LA and Magdalena Estrada from Eisner Pediatric and Family Medical Center in Los Angeles. They'll be introduced shortly, but first I'm going to go through a few slides to get us started and make sure that we're all on the same page. Today we'll be looking at how community health centers can methodically implement comprehensive breastfeeding policies, and we have two great examples of that. And they'll share with us some of the details for implementing their policies, and you'll be learning how to do at least one of those in your own community health center if that applies to you. We'll also look at how community health centers and local WIC agencies and others can establish reliable and effective referrals and communications for collaboration. Excuse me. So that's what we're here to learn about today in a short hour, and it's packed with great information. For those of you who are new to our webinars or to using GoToWebinar, which is the platform online that we use, just a couple best practices to mention. If you're listening on your computer speakers, just be sure to minimize interference by closing any unused programs, especially any that are streaming data. Use a high-speed internet connection for the best results and a USB headset if you have one. And also, if you're listening via telephone, you should have found the phone number and access code in your confirmation email, and then you would have gotten a PIN as well to enter, and hopefully you're not having any trouble listening in. We have found occasionally that there's some data streaming interference when you're on the phone, so store away any wireless devices if you have them nearby, and please don't put your phone line on hold. Everyone is muted who's participating on this webinar, so the mute shouldn't be an issue, but putting a phone line on hold, and sometimes there's music in the background or whatever, can interfere. So we appreciate your helping us out that way. If you do need help and run into technical difficulties, go to support.gotowebinar.com or call the number here. All right, and we just wanted you to know that we really welcome your questions during the webinar. Today we'll be taking them after each presenter. So we hope that throughout, as you're listening, you'll type any questions you have into the question box on your control panel and send that along. Karen and I will review them and share them with the presenters so they can be answered in the time that we have. And just a reminder that this webinar is being recorded, and we will post the recording for 2 months after, shortly after the webinar happens, and then it'll be on our website for a couple months, as well as the presenter's slides files, so you can always refer back. For those of you who are registered dietitians and wanting to get continuing education unit for this webinar, you must have registered in advance. And if you're sharing to look at this webinar on a shared computer with a group, we just need to know who was in your group, and each of you must have registered. So you can contact Megan Sadler at the email there, msadler@calwic.org. You do need to attend for the full hour, and if all of those things, criteria are met, you'll get a certificate via email within a week. We do hope to be offering continuing education for other professionals on future webinars, and we're sorry that we can't do that at this time. For those of you who are new to California WIC Association, just very briefly, we're a nonprofit member organization representing California's WIC agency directors and a whole host of partners and supporters. We provide training and staff development, public education such as this webinar. We do advocacy, research, and policy analysis, as well as all of our communication channels. So we hope that you will join with us in what we do, that you'll check out our website for the resources we have available to the public, and consider becoming a member. With that, I'll pass it on to Karen Farley, our program manager here at CWA.
Good morning, everyone, and thank you for joining us for the webinar. We're very excited to share this information about improved breastfeeding support in community clinics. This is something that clinics in California have been working on for a few years. And I just wanted to mention that these two clinics also participated or were recipients of small grants that were part of a larger grant from the CDC that went to the California Department of Public Health Obesity Prevention Program. And that helped them jettison along their efforts. But these clinics have been committed to improving breastfeeding support for a number of years. Some things that you'll hear today is that these clinics are implementing comprehensive policies and practices, much like we ask baby-friendly designated hospitals to do. They're looking for outcomes. They're looking at sustainability. Their work doesn't depend on grant funding. And they're looking for collaboration to build that continuum of care in their community. So I just wanted to turn it over to Dr. Jonathan Goldfinger, who's the director of the Lactation Clinic at AltaMed Clinic at Children's Hospital Los Angeles. He's also attending physician. He will present and then take questions, and after that we will hear from Magdalena Estrada. Welcome, John.
Thank you so much, Karen. I hope everyone can hear me.
Sounds good.
Thank you. Good morning, everyone. Thank you for joining us. We really appreciate the opportunity to present our lactation clinic. As Karen mentioned, it's been a beautiful labor of love over these past 2 years, and we've had some incredible results that we're excited to share with you. The title of my presentation is Implementing Breastfeeding Support. As you know, that's what we've been doing, with a real focus toward quality improvement, surveillance, which is a public health term for tracking outcomes data over time in a population. That's my area of expertise, actually. Karen can tell you I love data evaluation and data analysis, and making sure that we have really good data as a foundation on which to grow our programs, which I'll show you has been a great success. And billing, of course. We have to make sure that we are sustainable outside of our grant funding. So, as was mentioned, we started out here with a quality improvement initiative. We reviewed with the administration of AltaMed Health Services Corporation, the largest not-for-profit outpatient federally qualified health center in America. They have many, many clinics, and I'll show you where they're distributed. But essentially, we reviewed with their administrators, who were very excited about this program, what would be important protocols and policies for breastfeeding-friendly offices. And this is based on the Academy of Breastfeeding Medicine's protocols that you can find last revised in 2013. As was mentioned, policy is very, very important. So the number one is to establish a policy. AltaMed had already had in place a pretty minimal policy about the importance of breastfeeding, and we just kind of ran with that. We already recognized that we offered cultural and ethnically competent care, and we, in my clinic at Children's Hospital, did not provide antenatal care, although we recently contracted with some OBs, so we will be engaging in that as well, which is exciting. So we were really doing the postnatal care, and we realized we probably should still do a prenatal visit. When I started this project and asked our professionals if they did a prenatal visit, most of the pediatricians said no, but now we've started to do it, and during those visits we show our commitment to breastfeeding. We support baby-friendly. Our local birthing center, Hollywood Press, just became baby-friendly very recently with our health. So it's been an exciting journey, both inpatient and outpatient. Encouraging breastfeeding so that we can avoid formula, glucose water, or other liquids unless medically indicated. This is actually very, very important, and something that physicians especially have to be shown and educated about and stressed about, because number 6, the follow-up visit at 48 to 72 hours after discharge, is actually not that common. So make sure, if you're working with clinics, that you have a strong tie to the birthing hospital and you're able to get the patients in sooner rather than later, because physicians are really concerned about excessive weight loss and jaundice. And some of you may have been at a conference we had a few years back at Children's Hospital where David Braun of Kaiser showed that there actually is increased weight loss in jaundice in breastfed infants. So this is not a thing that physicians are just stating they're concerned about. It's been shown to be true, but most of that is physiologic, meaning completely normal, and important to stress to physicians with adequate breastfeeding management, especially ensuring access to a lactation consultant, that the weight loss in jaundice can be mitigated. So very, very important to address that with your physicians, and I get asked that all the time. Ensuring availability of resources, very important. Encouraging breastfeeding in the waiting room. I've highlighted all these in green so that you can see the areas that we've really focused on that I feel have made a tremendous impact for our patient. Eliminating free formula. It was great to go through our clinic and try to see what was there. It was interesting to note that we actually had free formula that we gave away to families who were underserved. And at the time, unlike requirements for baby-friendly hospitals, we really couldn't afford to pay for the volume of formula that our registered dietitians were providing to families free of charge through samples. So this is something very important to be addressed, and we agreed internally to allow that to go on, but we would not allow the formula reps to come into our clinic. We would just take the samples, distribute them for families who could otherwise not afford it. So every organization has to decide for itself which of these protocols they can implement, what's realistic, and most importantly, what's actually best for the patients and families. Encouraging mothers to exclusively breastfeed for 6 months. We've always done this, but we had to stress it further for our pediatricians. And then having a lactation room with supplies for employees who breastfeed, very, very important to support employees, and that will lead to better support of families. Maintaining a list of resources, always very important. We are the most significant resource right in our area, but there are others, including local WIC sites, and we do maintain a great relationship and share clients. Support and advocate for policy. That's something that I'm very interested in and has been very crucial in getting the services that we need, especially incorporating breastfeeding care into routine health services. When I started at Children's Hospital and started working with AltaMed, neither had internationally board certified lactation consultants on staff. Now both have on the inpatient and outpatient sides, and breastfeeding rates have increased because of this. So it's very important to teach your administrators that having adequate, appropriate breastfeeding care should be part of any standard of care in healthcare organizations that are trying to grow. Of course, enforcing laws where applicable, very important. All physicians should receive education. I actually was fortunate to present both to our residents in the preclinical years, to medical students, and to our attendings. We have volunteers all the time come to the lactation clinic, which is great, and then tracking the rates, which I'll show you. So like I said, I'm a surveillance buff. I love data, and I love to utilize it to create sustainable programs. So here's data from the Maternal and Infant Health Assessment from 2010. There's probably more recent data, but this is the one I have. And what you see is that the California average is 31.6% of women that can exclusively breastfeed at 3 months after delivery when asked. Note that by 3 months, the exclusive breastfeeding rate in Los Angeles is arguably lower than the average, though the confidence interval does overlap California. But when we looked at this, we said, this is kind of what we're looking for in our own data, about 25 to 35% in women. Here's what we were able to get out of our medical record. For the first visit, we looked at what mothers told one of the providers from July to April in terms of their breastfeeding. And what you see is the same thing. You have the same drop in exclusive breastfeeding rates. We utilized AltaMed's 2 largest pediatric clinics in Los Angeles to take a look at this data. And this was before the grant that we were looking to see, would the data that we get actually reflect appropriately what's going on in Los Angeles? And it sure does. Right there you see between 25 and 30% of women exclusively breastfeeding at that 2 to 4 months. Note also that when you use an electronic medical record, you're going to end up with some glitches, such as at the 22 to 30 day mark where the Commerce Clinic in purple drops down. That's an indication that not that less women were exclusively breastfeeding, but actually that the system was looking for cases and they didn't have that many women coming in with babies at that age. Also note the very, very large volumes of patients that you can get from even a single clinic. In under a year, Children's had 1,800 visits and Commerce 500. So EMR data is very, very powerful, and I encourage you to work with your EMR vendors to get data. And then we looked at these numbers for all of AltaMed in order to promote these quality initiatives with the corporation and compared them to formula feeding. And what you see, I like to call the march to formula, the same drop in exclusive breastfeeding rates in green on the corporate level, so it isn't just those two sites. So all the sites of AltaMed that I'll show you are being queried by this, which is many, many patients, as you can see, 5,000 in under a year. And these mothers are just slowly but surely giving up on breastfeeding in a pretty linear fashion from the moment the baby is born. And then what you see is that combined exclusive breast and both, which together would be the breastfeeding rates, start out pretty high, in line with national averages in the 80% range or so. But the march to formula goes on also in a linear fashion. And this is what we really have to address. So we looked in to see what are the causes of this and how could we best help mothers. What we found is a great survey by WIC, actually, in LA County in 2005, where they queried mothers to see what are the reasons that they stop breastfeeding. Note that these numbers don't add up to 100%, and that's because mothers have more than one concern. So we were really just assessing the frequency of specific concerns in this population. What you see is the majority of women feel they don't have enough milk. That can be real, and it can be perceived. In my experience, it's more often perceived than real, but it often takes professionals to guide mothers and show them that this isn't the case. Breast milk did not satisfy the baby, so the top two are really related to the mother's ability to give milk and transfer and realize that the baby is transferring milk and getting satisfied. Having difficulty nursing, that's probably more of a real concern than a perception. And nipples being sore, cracked, and bleeding, that's obviously a very real concern and something that can be dangerous and detrimental to the health of women. So if 1/4 of women are experiencing that, it's very, very important that we're able to address that. So this is the lactation clinic that we developed based on this data and backdrop, and as Karen mentioned, with the funds from the CDC through the California Department of Public Health and another small grant through the AAP, we built what's called an interdisciplinary team using different providers with different experience backgrounds and different credentials, and together we help mothers. In our case, it's almost always a physician, a medical doctor, usually myself, and an internationally board certified lactation consultant. We've also had RDs, and we're in the process of getting an OT on staff. So we really can create a robust team. This is actually our first patient up here, okay, and the case is actually great to highlight because what you see is an inter-ethnic couple, so that they had very different cultural norms within their families about breastfeeding, and it was important to address both. A mother who struggled with postpartum depression, and I've asked her permission to share that, and she said absolutely. So it's always important to recognize that the emotional health and safety of the mother and health of the mother are a crucial part of this. It isn't just about the baby, even though I'm a pediatrician, and the baby right in their hands. In one of our first encounters, breastfed exclusively thanks to our help for 15 months last I saw them. So as mentioned before, this is a very, very powerful opportunity to intervene and help families in those crucial first months where you can really make a difference. We address the mother and the newborn health and well-being, as I mentioned, and that includes a lot of different areas. So I would encourage you to look through these bullets when you have the time. I know Karen and company can share the slides, and make sure that you're really addressing these issues, because if you're not, I would suggest that you might be missing some very crucial aspects of the care of a breastfeeding dyad. And these are our many partners, having multiple agencies involved, getting heavily supported by those agencies, everybody in agreement about what our mission was, and of course including local pediatricians, very important, IBCLCs, and parents in the discussion about how to create this kind of service really leads to success. So thank you to the COIN Collaborative, which was the name of the grant. We now regularly measure our breastfeeding rates, as I showed you, and since we do, we know that greater than 95% of the babies in our clinic are being breastfed, and their mothers are reaching their personal goals. 53% of babies who come through lactation clinic are exclusively breastfed through 9 months. I'll show you that. And we use as controls the general pediatric clinic at AltaMed at CHLA, which was always there, and we compare the babies that were seen just by attending pediatricians there to babies seen in our lactation clinic and babies seen outside in all of AltaMed's clinics. Families are very excited about the help that we provide. They're always excited to give back because of that, and as Karen mentioned, it's so important to mention that we are successfully billing all insurance types, and I'll show you that. Some have asked me along the way, well, how do you get the data? So if you use NextGen, this is an older iteration of the EMR, but essentially we looked up the fields that were specifically meant for documenting nutrition, and in this case, the nutrition of an infant. And what you see are a bunch of fields that show different places providers could type the volume of intake of formula, milk, juice, water, and little check boxes for bottle, cup, breast, and then data on the breastfeeding. So in our query, the system would look at this case typed in and say, okay, they only checked the breast checks box. There was nothing for the others. This is an exclusively breastfed baby. In the next case, what you see is they checked the bottle, but actually they only typed into the milk area for breast milk. Usually we found that providers were not using this for formula, only for breast milk. So in fact, this was a good way of showing babies who would meet the WHO criteria for exclusive breast milk feeding, and we include these as exclusive breast feeders. And here, of course, are babies, or a baby who is doing both. And as you can see, they're on Prosobi, but they're also breastfeeding, so this would be a baby doing both. If they get rid of the breastfeeding checkbox, it would be exclusive formula feeding. Here's what the data looks like when we actually compare our success to that of other clinics. And what you can tell is that the lactation clinic patients throughout the grant period of a year, from February to January, in the light blue, start out breastfeeding at almost equivalent rates to the patients who are just seen by general pediatricians at CHLA. So you can actually see that we're dealing with the same population when they get out of the local baby-friendly or not-so-baby-friendly hospitals. But as you move forward, what you notice over here is that the blue, the light blue, increases, whereas the dark blue decreases. And so what that actually shows us is that mothers who are in lactation clinic are more likely to continue exclusively breastfeeding. Here's the 2 to 4 month olds that I mentioned before, near 60% compared to over here, only 25% for the general pediatricians alone. And all AltaMed sites overall had done more poorly than our general pediatricians. So it's important to look at data like this and show that you have roughly a 2 to 3 times more likelihood that babies will be exclusively breastfed past 6 months per AAP and all the other institute's recommendations when they're seen by our interdisciplinary lactation clinic team. When they're just seen by physicians at CHLA, it's not as successful, and when they're just seen by physicians outside our clinic, not as successful. So very, very important to show that data. As mentioned, here are the AltaMed clinics, and these are essentially where AltaMed has sites in Los Angeles. What you see here is the 60% that I showed you for exclusive breastfeeding rates, but throughout LA County, really only in the 20s, very similar to that data we looked at from the MIHA study. Here's Orange County, and these are the AltaMed sites in Orange County and their data. Same thing, they tend to be a little bit on the higher end because Orange County breastfeeding rates in general are actually higher, so we know that these rates are appropriate. And here's the most exciting part of our grant, in my opinion, other than the happiness of the mothers and the health of the babies. This is Santa Ana, Maine, AltaMed's second largest pediatric clinic, and they actually have all sorts of care there, not just pediatrics, but what you can see is that they started out with 24% breastfeeding rates, similar to our site, and AltaMed said, hey, you know, this lactation clinic model, it works great. Let's set up another one. So we worked with Santa Ana, Maine to get the data, and I'm really happy to share that they got a tremendous grant from the GE Foundation, and they've created an interdisciplinary lactation model. And this is the data before the grant. We still don't have the data yet since they just went live a few weeks ago. But essentially, their data shows similar comparing to all AltaMed clinics. They may even have started out with even lower breastfeeding rates. And this may be because they see a very broad array of patients from a larger surrounding area than other AltaMed clinics, and so they may end up very similar to our clinic at Children's with much more complicated patients. So we're very excited to see the increase in breastfeeding rates in this little pink bar, very similar that we saw in our lactation clinic. Last but not least, as I mentioned, the billing. It's very important to recognize that we have a very large portion of Medi-Cal patients here. We have a nice size of managed Medi-Cal care patients who are being seen by our clinic, so it really is predominantly underserved families who get helped. And as you can see here, these are our insurance payments. Okay, note that Medi-Cal themselves, in most of the columns, are actually doing pretty well. Care First is paying us about 70% of claims. Blue Cross Medi-Cal, 77%. It's not 100%, and you could argue that this is against the Affordable Care Act requirement to pay for these services, but we will hopefully be able to engage them directly through work with CWA and other organizations to address this. What you also see, which is a little bit sad, is that some of the PPOs are paying at a very low rate. If you look at Cigna and you look at others, Blue Shield, Blue Cross, so some of these organizations really have work to do, and we have to sit on them and lean on them to pay, because this is now a federal law. And then we are able to break it down by the babies versus the mothers. I didn't mention, but we register and we bill for the care of the mothers as a lactation consult, which is very important and recommended by the American Academy of Pediatrics, because even though we're pediatricians, we are licensed appropriately to help mothers, and most of what we do is counseling families and mothers, so we really should be billing for that care. But what you see is for the babies, we get paid more than for the mommies. So very, very important for us to address this. Maybe it's because I'm a pediatrician and I'm not as used to billing for mothers, and more likely I would argue it's because the companies are not yet engaged in paying for lactation services, as I have faith they will in the coming years. So same thing with the PPOs. Note it's even lower for mothers. So PPO insurance is actually behind Medi-Cal when it comes to paying for these kind of services. Look at Medi-Cal here in the managed Medi-Cal area. That's the end of my presentation, and I'll be happy to accept any questions you may have. Feel free to get in touch with me through Karen and CWA. I'm always available, and I do a lot of consulting work helping organizations like this.
Thank you, Dr. Goldfinger, for that fantastic presentation. I think you really touched in a short amount of time on a lot of work and a lot of key issues that you've been able to address to really build a successful program and be a pioneer here in California and the U.S. for breastfeeding-friendly community clinics.
Thank you. I appreciate the opportunity.
The only question that we've had has been if you could just clarify how you dealt with the free formula and the clinic purchasing of the formula and that decision.
Yeah, that's a really good question. So right now there's no designation baby-friendly like there is for BFHI, the Baby-Friendly Hospital Initiative, nationwide for hospitals. We actually tried to get baby-friendly, and Trish McEnroe to consider designating our children's hospital baby-friendly, but they wouldn't because we didn't have births, so we couldn't meet some of the criteria exactly, and it's something they looked into. Because of this grant, California is actually going to be even more advanced in establishing very clear criteria for what we hope to become a nationwide designation for clinics. Without those very clear criteria and a designation to kind of dangle as a carrot in front of our administrators, we ended up with a heated debate about the use of free formula, which is actually given, like many medication samples in many practices, to families who can't afford to buy formula and for whom WIC or local resources might not get them the formula exactly the type they need when they need it immediately. So we have a lot of very complex babies who come out of our NICU with congenital heart disease and many, many other complex conditions. Children's is a referral center through for the entire western United States for complex pediatric care. And we have a lot of these patients who need very specialized formulas, and unfortunately the systems of care are not in place to fully get them all of the formulas that they rightfully need, medically justifiably need. So with the ongoing discussion, it was accepted that for now we would keep the free formula samples that were being used at the same time while we figured out better mechanisms to pay for those samples. We agree that accepting free samples is not ideal, but we also take a harm reduction approach, and we're not just going to dump those families on the street without the formula that their babies rightfully, appropriately need with a physician prescription or a registered dietitian who is also a lactation consultant offering them the sample when they need it. So that's how we compromised and agreed to accept it. I think the concerns about free formula samples come from hospital formula bags where they're just routinely given out. I actually work with a company called Cottonwood Kids that gives out now a free breastfeeding bag, which is really incredible to supplant those formula bags. But that's not what we're talking about in the clinic. We're talking about samples that were given to dietitians to be offered to families unable to get formula that's medically appropriate. And that's kind of what was agreed upon.
Great, thank you.
I hope that answers the question.
Yes, thank you. It is a work in progress, and I think you underscored it, medically needed and appropriately provided.
Yes,
while still
absolutely.
Supporting breastfeeding.
Yeah, we actually toyed with the thought of having it prescribed by a physician, but in our clinic, as you saw, the numbers are exceedingly high. We see so many patients with so many different provider types that we did not want to restrict the dietitian's abilities to hand it out in waiting to find a physician to write a prescription, etc. So we agreed that those with appropriate experience and credentials who are all breastfeeding advocates. These are not people who buck at breastfeeding. In fact, the original RD started our lactation clinic with me. So we're all huge breastfeeding advocates, but we recognize the importance of formula at times, and so all of us are able to give it to patients, those that are in need. And we don't routinely, like I said, allow the formula company reps to do any kind of advertising. There are no advertisements in the clinic, and as people might not recognize the structure of our clinic, it's very, very large, and the lactation clinic is actually inside the general pediatrics clinic, and the lactation clinic is actually far away as you can be from a locked office which has the formula bottles. So that's as close as we can get right now to banning the formula.
Great, thank you. Another question is, how did you get your IBCLCs credentialed for billing, or did they work under another licensed provider?
Great question. We've heard, and we have not actually pursued this ourselves, but we've heard that IBCLCs with NPI, National Provider Index Number, should be able to bill on their own. As far as I know, we have not found a federally qualified health center. Magdalena could probably speak to this. We haven't found a federally qualified health center where done routinely, and we've looked. But that doesn't mean it can't be done. It just means that some of the billing mechanisms for this type of clinic may have to be tweaked. So our IBCLCs all bill under the physician. We use a model similar to what we do with our residents and trainees, where they'll see the patient either alone and then powwow with the doctor before the billing is submitted, and they'll type part of the note, and it'll be clear what their portion of the encounter is on the note. And then the physician will bill it, or they'll see the patient with the physician together. Because of this, unfortunately, every patient, even the ones that don't really need the physician, end up seeing the physician because the physician can't bill without at least laying eyes on the patient. So it's a little bit tricky, but because the interdisciplinary team recognizes the exceptional value of having the different types of providers with different experience and credentials, we feel it's completely worth the cost. And we've been able to sustain this with the physician's billing. Eventually we'd like the LCs to bill, but I would be a little bit concerned that we would be taking a little bit away from some of the families. And the feedback that we've gotten is having both providers see the family on the same day is very, very much appreciated. There are many things that the LC might miss that the doctor might pick up on, and things that the doctor might miss that the LC might pick up on. And this is a model used by children in many, many different subspecialty clinics that we have. So we have a ton of experience doing this, and it's very, very effective.
Great, thank you. And we have a number of other questions, but we really only have time to take one more, so Karen will ask that for you. I just want to remind people that we do have a record of your questions, and we will forward these to Dr. Goldfinger after the webinar. So if there's anything that he would like to follow up on, we can do that. He can do that through us, or you may be able to contact him directly. Karen, what did you want to?
Okay, we're just going to pick one last question here, and John, what would you say are the most effective ways for encouraging physicians, including pediatricians, to adopt breastfeeding-friendly policies and practices in clinics?
That's a really great question. The short answer, I know we're strapped for time, is data. Physicians are indoctrinated with the notion that research and evidence-based practice should drive how we care for patients. So if you go into the room and say, well, breastfeeding is great, rah-rah, and we have pom-poms or something that to them smacks of more advocacy than data-driven, they're not going to respond. And this is what we see in a lot of hospitals where they feel almost as if, sadly, baby-friendly is rammed down their throats by very vocal advocates. So I advise a lot of non-physician healthcare providers, go in with data. Show them that the Agency for Healthcare Research and Quality did a meta-analysis that absolutely proved that breastfeeding and exclusive breastfeeding are better for the babies. Go in and show them Melissa Bartik's article showing the billions of dollars that we could save if we could get more mothers to breastfeed. Go in and show them all the other studies that are out there every single year. We have thousands of articles coming out about the health benefits to the mother and the baby and even the economy of breastfeeding. So when you show them actual data, they're much, much more likely to comply. That would be the single most important thing in my experience.
Great, thank you so much, and thank you for presenting. We know you have to move on to another appointment, but we want to thank you for sharing your information. And Dr. Goldfinger's slides will be on our website after the webinar, and we encourage you to follow up.
Thank you so much for having me.
Great. Take care.
Okay, now we would like to welcome Magdalena Estrada from Eisner Pediatric and Family Medical Center, also in Los Angeles. She's the Health Education Supervisor and International Board Certified Lactation Consultant. And Magdalena has also been a pioneer in developing comprehensive policies and practices in her clinic at Eisner, and she has a lot to share with us today. So welcome, Magdalena.
Thank you, Karen. I'm very happy to be here and share this information with everybody. And so I would like to start by giving a little background about our health center. Eisner Pediatric and Family Medical Health Center began in 1920. It was renamed Eisner Pediatric in 2002. In 2003, it was federally qualified as FQHC. And in 2007, acquired the Women's Health Center from California Hospital, and that was the time that I was able to come on board. We're located in downtown Los Angeles. 83% of our population served is Latino, and our client population is 150% below poverty level, so most of our clients have Medi-Cal as insurance. We provide prenatal care. We have our midwifery service and pediatric care, which is a great combination of services prenatally, postnatally, and of course follow-up with infants. We have about 90 new prenatal clients per month, And our AltaMed Pediatric and Family Medical Center OB panel delivers about 100 babies per month at California Hospital. We were very fortunate, very lucky to participate and be granted the CDC breastfeeding grant in 2013 as part of the 15 clinics that were awarded. And so our first way to start this program was by getting organized, and we created a breastfeeding task force with tremendous support for from senior management. One of the things that were very helpful was to increase breastfeeding supplies. We initiated data collection. We also initiated staff training, completed 5 CLEs, were able to complete the UCSD lactation program, and we were also able to explore billing options for our center. AltaMed Pediatric and Family Medical Center is also a state-approved comprehensive prenatal services program. So traditionally, we have had individual assessment for clients prenatally by trimester and also in the postpartum. We provided group breastfeeding and infant feeding classes monthly, and we also have traditionally offer breastfeeding support once a week. We noticed that clients were having difficulty attending those appointments, and we were able to also adapt a policy to offer taxi transportation for clients in need for those visits. This is just showing us the different events that we have for clients. We're very strong in prenatal education and doing partnership with other different community agencies that also provide education and provide services. We were able to see, and we already had in place, billing for sustainability through the medical CPSP health education. All our breastfeeding services provided now at AltaMed are under the breastfeeding, for breastfeeding are under the CPSP education model. And since we are a federally qualified health center, the rate of pay for visits is the flat rate. This is just an example of the flow sheet for the CPSP program. So for health centers that have the CPSP program, they have the opportunity, as we do, to offer individual and group education. We also, in addition to regular medical, accept other HMO plans, medical HMO plans, and through those as well, we are able to bill for CPSP. We decided to work intensively in more education and do promotion internally during the grant time. And one of the things we did was started the managed care and outreach education. So we have a team that visits the hospital to provide appointments to clients, and they are the #1 way to actually get access to the patients to attend breastfeeding support. We also trained the phone operators. We found out that phone operators were receiving phone calls for breastfeeding questions and not knowing where to go, so they were trained to understand the services that we provide and schedule those appointments. In addition, the referrals and authorization team was trained to identify those prescriptions or referrals from pediatricians and also from the OB providers to be able to process them accordingly. We increased on breastfeeding education for the staff. We were able to conduct a Breastfeed LA survey, which is a questionnaire to evaluate the knowledge of all the staff. That included not only the physicians, but also all the medical assistants and the clerical support. We did different breastfeeding in services in partnership with the WIC program. We also increased we trained the Women's Health Center for the Breastfeed LA key points, and we're still in the process of implementing the program, but they received the initial training. One of our midwives became a CLE through the grant, and she was able to also provide a session on breastfeeding examination and also helping clients with breastfeeding intention. Every year, we promote the Community Health Center Week, and of course we also include breastfeeding as part of the Breastfeeding Awareness Month. As part of analyzing where we were, we realized that we have already breastfeeding in place, and our environment in the clinic it's very conducive to breastfeeding in ways that we do not have any promotion of formula. The Women's Health Center and Pediatric department has areas of information with breastfeeding. We do not provide any formula handouts or magazines to clients, and the documents that we provide or the handouts that we provide to the clients are requested most of the time from the WIC program. So we're very happy to have that partnership with WIC. The room that you're seeing here is our initial breastfeeding room. This is the actual prenatal education classroom that we convert into also breastfeeding room once in a while. But nowadays we have a designated breastfeeding room in the pediatric department. We were able through the grant to also analyze our electronic medical records and the data that we could get for breastfeeding. And as Dr. John mentioned before, we were able to find the fields needed for education. Most of those fields are not as friendly as you were able to see in his description of how the data was analyzed. It is hard to really get into all those fields. I really hope that in the future, NextGen and other medical record programs can make this easier. The table that we have here is basically for the documentation of the pediatric feeding, the feeding status. But for the prenatal client, the window is getting into the tobacco cessation section before getting to the actual breastfeeding status, which is not, once again, as easy to help with doing data, tracking the data. Our community-based model, it is briefly explained here. Prenatally, we have prenatal education in place, full-time educators conducting the classes, and also doing once-a-week breastfeeding support as an IBCLC. Midwives and all the OB providers encourage breastfeeding, and we also have the connection with the WIC program, good support from the WIC program and information available. Through California hospitals, the CHFC, the maternity hospital tour guides inform also clients about the skin-to-skin and golden hour standard. So patients get different areas of information. At the time of delivery, California hospital has one lactation consultant, and there is some support available as well. Unfortunately, there's only one IBCLC for all the over 4,000 deliveries that the hospital has annually. Our outreach worker, as I mentioned before, visits the hospital to provide the follow-up appointments, and that includes, of course, the breastfeeding appointment as well. We are very fortunate to have the Welcome Baby program in the area, and the Welcome Baby liaison also runs the hospital for postpartum mothers and provides some support. In the postpartum time, ICE Pediatric and Family Medical Center has instituted the 3 to 5 days visit for the newborn, and that is one of the appointments provided by the outreach worker when visiting the hospital. We have the one-on-one IBCLC consultations once a week, and all those consultations, once again, are part of those education visits, are part of the CPSP program. In addition to that, the WIC program, we refer continuously patients to the WIC program for support, and also the Welcome Baby program, the nurse home visiting program, continues assisting clients throughout the time of the term of the program, which is 9 months after delivery. In short, this is how our community model for breastfeeding support shows that is at Eisner at this point. You see in the blue area in the center, we have breastfeeding support with CLE or IBCLC, and I'm going to explain a little more about that, and the different sources of referrals for support. We have, number one, our outreach team visiting the hospital, who immediately provides the schedules the appointment for the client when she needs support. Our comprehensive perinatal health workers and educator also refers for breastfeeding support. Our Women's Health Center and all providers in different departments are also have the access to refer clients for breastfeeding support. Clients may be referred on their own. They know where to call and request an appointment or get assistance. And the pediatric department as well, when the patients come for the visits, they're able to also refer clients for support. On the right side, we see our community-based model with our partners in the area, which will be California Hospital, the Welcome Baby Program, and the WIC program. We definitely cannot do enough support for the clients if it wouldn't be for all the partnership of these stakeholders. We were very fortunate to get 5 of our 3 medical assistants, and 1 outreach worker, and 1 of our certified nurse midwives certified through with funds from the grant, from the CDC grant in 2013. And what you're seeing here is we put lots of effort encouraging our participants to complete the program. You can see here on the right, Chona De Leon, which she's our vice president, and Carl Cohen, our CEO at the time, who greatly supported our efforts to get more support for breastfeeding. We initiated a breastfeeding pilot project this year with the expansion and giving the opportunity to the new trained medical assistants as CLEs. And what you're seeing here is on the left you'll see decline support, meaning that at the time of visit in the hospital, many of our clients decline need or decline any support with breastfeeding. One of the reasons we found was because it was an extra day they needed to come for breastfeeding support, and they considered that way, too much, too difficult to come to so many appointments. In April, we initiated a project in which we included the evaluation of having a CLE in the pediatric department seeing clients at the same time of the visit to the pediatrician. As you can see, immediately there was a drop in declines of support, since the support was, of course, available at the same time. And the month of July, we did only 3 days of support, and you can see, again, kind of going up a little. So definitely having assistance, getting breastfeeding support on the same day of the newborn visit in the pediatric department, it is well accepted by clients. In 2012, in partnership with the Welcome Baby program, we were able to get this information. The exclusive breastfeeding initiation rates at a California hospital were 33.2%, and for the Welcome Baby in general participants was 49%. And happily and surprisingly, we found that Eisner patients, the rate of initiation of breastfeeding, this is based on the initial visit and that the Welcome Baby liaisons did in the hospital, were breastfeeding exclusively 59%. Now, of course, we need to keep in mind that clients that were enrolled in the Welcome Baby program were mainly coming from health education classes, so most of these clients have more education than the rest of the participants enrolled in the program. We also know that, of course, being part of the Welcome Baby program, these clients had extra support, and that may have some influence in their 59% breastfeeding. Nonetheless, it was extremely happy. We were very happy to know that our breastfeeding rates, in comparison with breastfeeding rates from other providers, are higher. Through the breastfeeding grant, once again, since we were able to analyze NextGen, our medical records, and see how we could find information, we were able to gather information for the CDC from April to December of 2013, and we were able to see also see that initial newborn visit, what was the rate of breastfeeding in that initial visit. And as you can see right here, the exclusive breastfeeding rate was not as high, but towards the end, we considered that this could have something to do with the impact of education done through that period of time, more support developed. Also that exclusive breastfeeding rates were increasing. We're very eager to know what will be the data this year. By the end of the year, we'll see how it's been, how the rates are changing, especially now that we are adding our CLE support in the pediatric department. In general, our breastfeeding rate for those first visits and the clinic, the exclusive breastfeeding rate is 39%. That's the overall breastfeeding rate. Formula 17%, and any breastfeeding for 44%. We can see that the data from 30 to 60 days, there is a drop, and once again, that was the general overall. And after 61 days, exclusive breastfeeding data shows 23%, which of course is kind of more in line with the general rate. Our goal is to analyze again with all the support that we're developing and see how these rates can go up to support these mothers and babies. We were also able to incorporate more policy, the breastfeeding policy for the employees. And in June 2013, we opened our breastfeeding room, our lactation room for employees. And as you can see right here on the left, it's a very small space. We're very comfortable, and everybody is very happy about the implementation of this room. We have a policy in place and an agreement on clients participating, in this case, I'm sorry, employees participating on the Lactation Accommodation program. As well, through the CDC grant, we were able to get a few breast pumps, the one that we see in the lactation room, but also the one that we see on the right here. One of our employees, it has to be moving from site to site since we have the school-based program, and she's able to continue exclusively breastfeeding her baby. She was the one who took this picture to show us how much milk she's actually producing, and so glad that she's able to do this. This is the impact on that this open house created. We have our CEO and members of the Breastfeeding Task Force here at Eisner, our Chief of Operations, and the Director of the Midwifery Program, as well as our business development, grants development staff. And so we had a wonderful open house. We're also seeing the employees who did breast pumping without having the lactation room, and they were able to share how difficult it was and how happy they were for the new employees that had access to the lactation accommodation room. This was a big festive event. It was a big celebration in which all employees participating getting lunch and also visiting the room. This is our school-based supervisor who this year very graciously came to share her experience with patients as well during our breastfeeding support event. All these events really create an impact not only on patients but on the staff to get the entire environment of supportive and friendliness breastfeeding environment in the clinic. So building a breastfeeding-friendly community health center in 2014, we are doing a few innovations. One is we have dedicated medical assistants, comprehensive perinatal health workers who are increasingly working with the postpartum mothers for the postpartum assessments and their support. They're able to refer clients, give appointments to clients for extra breastfeeding support and give them information right at the time of assessment. Our pilot project, our CLE breastfeeding pilot project, is moving into 3 to 5 days per week during the newborn initial appointment hours to facilitate services for the clients, but also to assist and support the pediatricians with the assignment on providing more education and more assistance to the clients. The infant visit then and lactation support on the same day is our goal, and follow-ups with an IVCLC 1 per week as it is needed. We're also navigating more the referrals for the breast pumps, the DMEs, which has been a challenge, but we continue navigating and always finding ways to refer clients for breast pumps. And we are working on implementing the breastfeed education tool in the prenatal area. There are always challenges, and as we look forward after implementing the different policies, different services in place, a way to actually keep on documenting. We're improving documentation, but we're also working hard on trying to get some more data. We see that we have to work harder on how to improve patient flow for breastfeeding and the pediatric department. We also have the challenge, of course, in assisting clients as soon as possible in the hospital within the first days, since the rate of breastfeeding from the hospital by the time they come to the first initial appointment has considerably dropped 10% in such a short period of time. We are constantly looking at ways to maximize revenue by providing services when the patients need it. We're working hard on improving our data collection and being able to get reports. The ongoing education staff, it's very time consuming. Once we know that education is done for the staff, we find out that, of course, new staff is coming, and we have to constantly keep on educating everybody. Our goal, of course, is to reduce barriers for the mother and for the infant to increase breastfeeding. And so this is all the these are all the implementations done, and thank you very much for all the support from the CDC. The grant was a tremendous support, but as well as all the support of the staff. Thank you very much for listening to this presentation. Let me know if you have any questions.
Thank you, Magdalena. That was very thorough and very comprehensive. And I'm really happy we're able to share your slides, because there was just so much there on all the different aspects you've been working on. We did have one question, and that is if you can clarify, this may be a long answer, but maybe you can give a short version of how you're able to use CLEs, CLCs, and IBCLCs. I know you're piloting the use of CLEs. Folks had a question about that.
Well, through the CPSC program, the IBCLC or CLE does not need to be a medical provider, but it could qualify as part of the CPSC provider. So the way we work this out is we work directly with the providers, either midwives. The CLE works under the midwife or under the doctor of the day, and in the pediatric department also under the supervision of the pediatrician. So health education is covered in general under CPSC for breastfeeding support. I really hope this kind of clarifies how we are able to do it, which is a little different than what John was mentioning about how they do it directly as providers, since doctors and nurse practitioners can bill as providers. In our case, we do all the breastfeeding support under education for the CPSC program.
Right, so different models.
Exactly.
Another feature that you mentioned or aspect is that you have staff actively going out to hospitals, and that's a really nice reach across in the community and warm handoff. Do you feel that's been had a positive impact as far as mothers showing up in clinics and following through needed breastfeeding support?
Absolutely. This is the goal. The initial goal was to be able to provide those pediatric appointments, the newborn evaluation appointments for the clients, and also the postpartum follow-up, since our data show that our rate of postpartum return was only 36%, which we were shocked to find out that was happening some time ago. With the visits to the hospital, the intention was to really help clients get those appointments, assist them with those appointments before they leave the hospital. We added the breastfeeding support to those visits, facilitating them at that point if the client had any difficulty breastfeeding, any questions, to actually provide those appointments as well. we're moving in the direction of now kind of verbalizing in a different way, or present it to clients in a different way, because we find that usually the way that we present breastfeeding is as look for support if you have a problem, instead of that, you know, we are here for the infant feeding. So we're moving more towards also providing this service in general for infant feeding. So infant feeding support, not only breastfeeding, but also assessing the feeding at the time the client comes with the baby for the pediatric appointment.
Great, that's good to hear, because we have heard from our work with clinics that that obstetric follow-up is always a challenge, and then getting the hook for the pediatric follow-up and getting the mom in and the baby in to be seen is always more beneficial than waiting too long for anything.
Absolutely, yes. It is a challenge to really see the flow of the day, and that's what, you know, we're working hard on seeing what's the best way to do it. The way we do it is we have the pediatrician examining the infant, and right after that, in the same room or moving the client to the breastfeeding or the lactation room, offer the support at that time, clarifying any questions, giving any guidance.
It's also great collaboration with the hospitals, who really need to know that the support is out there for step 10 of baby friendly. So that's another really important aspect of that strategy.
Absolutely. Having the access to go to the hospital and working also with outreach in the hospital. Although we do not have the relationship, the strong relationship as we used to have with the CLE in the hospital, there is still a really good connection since our OB panel is in charge of delivering the babies at the hospital. They're also able to provide more support and identify clients that need assistance. And in addition to that, through the outreach at California Hospital, working together with our prenatal department, we're able to also link the education, link the resources, and get referrals back and forth.
Great, thank you.
Great, thank you so much, Magdalena. Just a tremendous amount of information, and we've had some other questions, but we are out of time. We appreciate those of you who have been able to stay a few minutes beyond our 12:30 scheduled end time. But thank you so much, Magdalena, and we'll post her slides and the recording of the webinar on our website shortly. And we're so glad that many of you joined us today. We hope you will consider joining us next Wednesday for our last breastfeeding-related summer webinar on hospital policies. So with that, we're going to say farewell and until next time.
Thank you. Have a wonderful day.